geriatric psychiatrist who has talked to us earlier about dementia and is going to talk to us today about how depression and anxiety can be managed in older adults and understanding maybe some of the nuances and differences between younger folks and those who are a bit older dealing with these conditions. So, John, thank you so much for joining and sharing your expertise again. Really appreciate your time and dedication to this project. I just want to start maybe by asking you, really, what's your take on this topic? How differently do we see depression and anxiety in older adults compared to younger folks? Can you give us a perspective on that?
Sure. I think it can be very individual and it goes beyond chronologic age. I think it's well
Mm-hmm.
worth remembering that depending on people's greater medical health and their social setting, some people will have still very much a younger presentation despite
Mm-hmm.
being over the age of 65. There's nothing
Mm-hmm.
magic that happens on your 65th birthday. But some people are going to face some of the complications of medical complexity or frailty even at earlier ages. So
Mm-hmm.
there are some general trends or guidelines, things to keep in mind,
Mm-hmm.
but it's not that we should forget all the lessons we all learned about middle age too. All of
Mm-hmm.
those things still apply. There's just some different factors that might present differently. And the
Mm-hmm.
biggest thing I think about with older adults, and there's more research made on the depression and the anxiety side, but is not missing things because they're not typical for what we learned in our regular
Mm-hmm.
depression talk in training.
Gotcha. So what would tell me more about that. You're intriguing me. What specifically are you saying we should keep our eyes open for?
I think the two big things that come up are the opposite topics of underdiagnosing depression when we're not recognizing it, and then uh, inappropriately diagnosing depression when it really
Mm-hmm.
represents something else.
Mm-hmm.
Um, so there's maybe I'll start with the things that aren't actually depression. Um, the the big things that come up are either general medical conditions, especially when people are
Mm-hmm.
presenting with things like fatigue, apathy, hypersomnia, or insomnia. These are obviously very vague and could be lots of things. And even though someone may appear depressed, to not forget to run in our own head the list of what are their known medical conditions?
Mm-hmm.
Are those getting worse? Their prescription medications, and even things that we don't always think about as being as big a concern psychiatrically. We talk about antihypertensives and beta blockers in particular, but even some diuretics, certainly things like opioids, they can present people looking very depressed and being mindful of that.
Mm-hmm.
The other is going back to the dementia topic, people who have those sort of withdrawn
Mm-hmm.
experience of a dementia because either they're feeling socially awkward or they don't have the activation as part of their dementia. And so they sort of don't do much of anything. That can look very depressed and it's very difficult to tell. So it's I don't want to get necessarily into differentiating dementia and depression quite here. I think that's sometimes a challenge, but it's most important to be mindful of all of it. That when
Mm-hmm.
you see those things, have I run the medical list? Is there something on exam or other history that suggests I need a lab workup for another condition? When their medications be doing it? Do I need to at least ask about memory and cognition? Doing
Mm-hmm.
all that first
Yep.
before rushing too fast into an antidepressant.
Mm-hmm. Yeah, that's a great. I mean, I remember learning a while ago that, every symptom is a medication side effect until proven otherwise, especially as people age, since they just gather up meds. And another tip was if, to pay attention to when the symptoms started, and maybe
Mhm.
that's a great way to look at what meds were started at that time, because it can be daunting to look at all the meds sometimes. And then
Yeah.
I think this idea, which is so important, of getting a good history on the cognition and maybe involving family members. We've talked about that before, about the importance of expanding the history taking to any family members that, time is limited as always in primary care, but as much as possible, getting a perspective on onset and, what else might be going on. And then hopefully we're thinking about medical conditions, but that might be the first thing that springs to our mind, but those other two might be ones that we don't always consider. That's great. So we're talking about overdiagnosing depression when there might be something else going on. So that's one thing.
That's right. That's right.
Hmm.
And maybe one other specific thing I bring up is pain. So chronic pain is a
Uh,
tough one, and sometimes that your comment of getting collateral history, that's another place where sometimes people don't want to constantly be complaining about pain, and that if a family member says they're talking about this all the time at home,
hmm
that can be useful. And it's important to bear in mind we may be doing everything appropriate for those medical conditions. Our care may be fine. We don't have to be hard on ourselves about that, but it can still look like depression. So.
hmm Got it. What about underdiagnosis? When might we, are there ways that depression and anxiety can present? And again, we're sort of grouping all older adults into a big category. It's good to
Mhm.
clarify that we might have it's a heterogeneous population, but what are some ways that you see depression getting missed in this population?
So that same vagueness in symptoms sometimes means that we don't appreciate that a cluster of symptoms might be depression. So there's a few differences that maybe are trends in a difference between a depression presentation in younger adults and in older adults. Um, so uh, with older adults, we often talk about them having more somatic complaints. So they're going to have
Hmm.
more of these physical symptoms of it. They may have more trouble with insomnia or decreased appetite, some of the psychomotor slowing. And in younger
Hmm.
adults, we typically see increased appetite, more agitation, or maybe hypersomnia. So this is not an absolute rule, but it's a trend. And unfortunately, things like insomnia and decreased appetite happen to many older adults with or without
Right.
depression. And so these aren't always red flags by themselves, but if you start to have enough of them, that should be uh, at least something worth investigating.
Hmm.
And especially if you do run that medical list in your head and you say, maybe let's say I know they have a little bit of chronic pain, but their insomnia seems out of all proportion
Yeah.
to what I already know about.
Yeah.
What are we missing here?
Hmm.
That's a good sign.
Gotcha.
And
Hmm.
I think this is one of the great things about longitudinal care that we can see in primary care is you can say nothing's changed about their medical illness in the past 3 months, but suddenly some
Hmm.
feature of it seems worse.
Hmm.
Maybe there's something new.
Yeah. That's a great point, is the subtleties that can arise when you know somebody long enough to say, oh, this one variable might be the one that's changed, because
Right.
it can be very challenging. I think it's worth pointing out that this is it's a bread and butter and also challenging diagnosis to make at any age, but I think in some ways it gets more complex as people get older. The other thing that can come up, I think, with older adults is the role of grief
Mhm.
or social isolation, which we know is more prevalent as people get older. Can you comment a little bit about those variables?
So it's interesting. They're both common features of depression and their risk factors. So big risk factors for
Mm,
depression, older adults, medical complexity, cognitive impairment, disability and loss of function, social isolation. Actually, being caregivers is another one. So
mm,
the caregiver role can play a role in people's depression, but also then perhaps after that, if a loved one or if a spouse has passed away, that grief as well.
mm,
Um, and it's important for us to note and to I think be mindful of where we can and can't help.
hmm.
That we sometimes want to do everything. We sometimes want to very much medicalize the problem, and this is not really quite either. We can't solve their social connection problems out of a clinic,
Hmm.
but we should appreciate the role it plays and figure out how might people try to solve it, and then encourage them maybe with support. Here's a place where it's not just collateral information to us, but combined problem solving for a family or a support network. how might people get a little more engagement? Because um, with all these other things, so isolation alone can make it harder for people. But if they're, for instance, not driving or not driving as much because of their other medical issues, that just adds another layer of challenge. How are we going to help that?
Hmm.
And we can't always solve all their problems, but it's also not sufficient to say that they should socialize more.
Hmm.
We can maybe offer them a few ideas we might have. This is a
Hmm.
place where, whether it's behavioral health consultants or social workers, even just
Hmm.
giving us ideas of
Right.
tidbits we could offer to people and say, here are 4 or 5 things. Go think about what fits your family. Try
Hmm.
them. See if
Hmm.
that helps.
Yeah, I love that. One of the things I've learned in this journey of learning to be a better geriatrician is the role of senior centers. For example, just
Hmm.
one small piece. We have in the Northeast, we have what was formerly called the Hollywood Senior Center, now called the Community for Positive Aging. I signed up for their newsletter, thinking it'd be like a little one-page thing. It's a thick booklet every month, and in it, there's just jam-packed events, groups, there's case managers. There's a lot out there for people,
Hmm.
is what I've learned. And we as clinicians may not be as aware, but our social worker colleagues, our behavioralists, some of our care management teams, especially if someone is being case managed, if they're complex. So, yeah, we can help connect people to those resources, even if we ourselves might not be as knowledgeable. And it might be worth learning a little bit more about what's in your community, I think, too, because
Sure.
it's quite
Sure.
exciting to learn about, ukulele groups and like, things like
I think
that.
it's good to know a couple things, and sometimes even being able to tell family, you too can sign up for the mailing list. You
Yes.
can get this and say, here, pick one thing off that newsletter. Just pick one
Mm-hmm.
thing you think your loved one might enjoy and go take them. In fact, you might not even really ask, but just say, I signed this up for ukulele lessons. It's a one-time thing. We're going to go and see what works for them. What's going to meet them where they're at, what they're all comfortable doing, and different families have different ways of approaching it. But if you can tell people, here are a few places you can go and pick out what works for you,
Mm-hmm.
um, I think that encourages them to tailor it to their specific needs. And it's reasonably efficient for ours. Like we cannot possibly keep up.
Yeah.
So instead saying our job here is to just to offer some ideas, some places to get you started, and
Mm-hmm.
then iteratively come back. Tell me what worked and what didn't. We can brainstorm together. That can be very helpful.
Definitely. I think you brought up the very important topic of caregivers, both
Hmm.
as people at risk for depression and also folks that care for people with depression. How do you address or think about caregivers in your work? How do you approach that? I think there's sort of these shadow central characters that sometimes we're aware of, sometimes we're not, and it behooves us, it seems, to really try to figure out who they are if a patient of ours is a caregiver to really kind of understand what stressors they're under. How do you kind of navigate that?
Yeah, so I think there's two things. One, if I understood it correctly, I think is getting to know everyone in someone's life. We can't know it all, but I think as names come up, as references come up, trying to keep track of who are the players in their life, and recognizing that if people come in with, I'll say a more traditional or classic family structure that may be fairly straightforward, but if we start hearing a lot from neighbors,
Hmm.
it's a sign that maybe there's not as much other social connection. They're just people in the neighborhood who are concerned, but there's no one responsible figure. I think that's a great time, again, to ask for help from someone like social work. Like,
Hmm.
can you help us track down? This seems unusual.
Hmm.
Um, but it is helpful sometimes to have a knowledge of not only who's in the caregiving, but roles, at least in terms of who's making decisions, who's the most informed, which might not be the same person,
Hmm.
and who's actually physically there helping them.
Hmm. Hmm.
Um,
That's a
and
useful rubric to just think about the caregiver roles being divided often amongst siblings or family members, to really think of the
right,
caregiver role as more than one person, right? Hmm.
more than one person, and not infrequently, the adult children are at a chronologically at a stage in their lives where they're often quite busy and they
Hmm.
might formally be a power of attorney, but really not be up on the day to day. And that's fine.
Mm-hmm.
Totally fine. We just want to know who's doing what, so
Mm-hmm.
we know who to ask which questions, and try to keep it reasonably efficient. Um, I think when people are acting as when our patient is acting as a caregiver, and we think that's weighing on them, it is not always easy to get them to acknowledge the burden it places on them. Perhaps especially for spouses, or if they have a child who is still in need of their parental care, even if the parent is now in their 80s, say. Um, People tend to see that as their duty, their responsibility, and are are not always comfortable
Mm-hmm.
saying that it's hard or that it's difficult for them. They may be more able to tell you practically when it's challenging, but not emotionally. I sometimes nearly assume that it is, and
Mm-hmm.
just make some comment. That sounds like it must worry you. That must
Mm-hmm.
be, there's a kind of grief in the story I'm hearing from you.
Mm-hmm.
To kind of open the door, because for a lot of what we hear about, it would be very strange if someone didn't have that. Um,
Mm-hmm.
Maybe the most common I see is one spouse caring for another one who has a dementia. Uh, Almost entirely, there's some grief with that. So, I think just saying that
Mm-hmm.
this comes up a lot, and I frequently talk about these things in clinic, saying, "Oh, I hear a lot from people in your situation, whatever I'm thinking," to make it sound sort of normative,
Yeah.
and see if they agree with it, see if they sort of bite at that. And most
Mm-hmm.
people do. Uh, but I think trying to call it out as explicitly as we can is important, because we're going to want to know eventually before it becomes a crisis.
Yeah. So validating the caregiver. One of the things too I learned about, and I don't know how widespread this practice is, but at the VA, there is actually quite a bit of explicit support for
Hmm.
caregivers that I learned about. There's a curriculum for caregivers.
Oh,
There
okay.
is sometimes financial support for caregivers.
Hmm.
Obviously, that's a very, kind of rarefied environment, the VA. Some of our patients have dual
Some of it,
diagnosis
yeah.
and dual coverage, so it is worth thinking about that.
Hmm.
But it's just such an important topic. I think it would be nice if we had kind of something like that here. That's something I'm
Yeah.
working on pursuing, just thinking about what would that even look like. Um, you mentioned grief, which comes up for people even when
Hmm.
someone is still with us, right? If there's a loss. I understand that we have some group therapy around grieving, is my understanding. Do you know any specific, other than that, are you familiar with any other sort of specific resources we have around grief, as a
I
proxy for
I
depression?
only know of it in terms of actually of related to the hospice program
Mm-hmm.
specifically.
Mm-hmm.
Um, And so it's been a challenge in finding that,
Mm-hmm.
for people whose loved one didn't die on hospice services,
Mm-hmm.
although it's a very common topic. Um, I I don't know of any formal mental health resources on it. Um, we do have some people who go through sort of a traditional counseling approach,
Okay.
but it's
Mm-hmm.
also a great opportunity to think, like, what are there other connections
Mm-hmm.
around this? And I think especially for people who have a spiritual religious community, this is a topic that death and
Mm-hmm.
life and death is a very common topic there. So I think that is sometimes something I I want to make sure people are connected to that and getting
Mm-hmm.
some encouragement or support. It's also probably worth noting that it's not unusual, for a surviving spouse, especially after a long relationship, to have moments where they are ready to be dead, and that, like,
Mm-hmm.
this need not be a, a, a crisis around suicidal thinking. That is our nature in the medical system when someone talks about wanting to be dead,
Mm-hmm.
that it is a big deal, and it should be. But I think older adults know better than us that they are facing their own mortality in any case. And when we're talking about progressive illness that we're, on the one hand, telling them we can't cure, when we're talking about chronic pain that won't get all the way better, they're talking about grief and loss. Um, there's going to be these times, and what another thing we can't do, but they should think about, is like, where is meaning and purpose in your life in all of this?
Mm-hmm.
And as people decline in function, this is one of the things that's tough. Even just being unable to drive and go visit the grandkids because they don't drive anymore.
Mm-hmm.
Well, what is your role? And we can't answer that question for them, but I think trying to reflect what their role can be.
Mm-hmm.
There is a very specific form of psychotherapy directed older adults called reminiscence therapy, which is
Mm.
kind of just what it sounds like. You can almost sit down with an old set of photographs and go through the arc of their life, and it helps identify purpose and meaning. What was it all here for? Things like this.
Mm-hmm.
And we don't have to do the whole thing of it. We can just sort of reflect as we hear things from them about what they have done, what they have accomplished, and what
Mm-hmm.
they still mean to the world around them, which can be very hard for them to hold on to. We often define ourselves by what we've accomplished, what we've worked on,
Mm-hmm.
and there's more to it than that.
That's a really fascinating thought. And it kind of touches on some of the things I've read about in gerontologic research around
Hmm.
successful aging and the idea that a successful older adult will also kind of tap into this generative identity of being
Hmm.
able to pass on some knowledge
Hmm.
or connect to a community where they're able to, find meaning and purpose by giving back to
Hmm.
a community that they're connected to. So that's very cool stuff. I think the other thing that you brought up that's really important is probably the importance of understanding people's spiritual leanings and
Hmm.
community. To maybe be that have that be a part of our history to because that can open up, I think, a whole community of support that maybe we hadn't considered or thought about, which
Hmm.
can be a little bit hard, I think,
Yeah.
to ask those questions. But in this setting, it makes a lot of sense, I think, to do it, especially if we're searching for where are people getting support in their communities and we're looking for other ways for them to get it.
Right. And especially we're talking people who have advancing medical illnesses. A lot of older adults too. We're at some point, someone, if not us in primary care, a specialist, someone's going to tell them that they're approaching the end of their life. Like, we might as well be prepared and know something about it. Um,
Absolutely. Yeah, we don't do very well with that, do we? Well, we should. And
it's
I hope myself to get better at that. I struggle with that, I
it's a
think.
hard topic. It's a
Hmm.
really hard topic.
Hmm. Let's move over to treatment,
Mm,
medical treatment. We've talked a little bit about everything except medicine, which is great. That's where I like to spend most of my time.
sure.
But if we are talking about medicines, we kind of reach for things like mirtazapine, trazodone,
Hmm.
talk to Remeron. What are the things that may be different in terms of medical treatment of depression for older or anxiety in older adults?
And the biggest thing I think about is that we're more defined by not by what's the safety profile, the risk of making something worse,
Mm-hmm.
and usually that we're overlaying over a complexity of more medical illness and more other medications.
Mm-hmm.
So a lot of the recommendations don't change so much,
Mm-hmm.
or many of them are some of the things we already know that we try to avoid are more anticholinergic meds like
Mm-hmm.
Paxil, the tricyclic antidepressants. But there's uh, just in general thinking a little bit first about what's safe to give
Mm-hmm.
instead of what would be most efficacious.
Mm-hmm.
It still is primarily people are talking about things like SSRIs, SNRIs. So of the SSRIs, I typically reach for either Lexapro or Zoloft, so that's top
Mm-hmm.
or sertraline. Um, the SNRIs, things like duloxetine, there has sometimes been a concern about things like effects on blood pressure.
Mm-hmm.
It's usually pretty mild, it's like a few
Mm-hmm.
points. We can check that again. So I think
Mm-hmm.
this is an important thing where there are a lot of warnings that come up around effects on blood pressure, watching for renal function. What about that QT interval? These are all very checkable things. We can go
Mm-hmm.
do this. A lot of medications I hear concerns about are people saying, well, they're now on two medications that could prolong the QT interval. That's usually only a few milliseconds. So if they started at a corrected QT of 420,
Yeah.
I think they'll be okay. And if you're
Oh,
really
that's good to
concerned,
know.
you
I
can go
didn't know
back
that.
and check an EKG afterwards.
Mhm.
But the actual clinical risk isn't so great. It's and we should differentiate a little bit between like what is just sort of the warning label and what is that clinically significant risk.
Mhm.
We do, for instance, talk about SSRIs and the risk of like GI bleeding, especially people who are on chronic NSAIDs, things like
Mhm.
this. but the absolute risk is still relatively limited. Otherwise, the safety profile of an SSRI is great compared to a lot of the alternatives, so it should not do it. Um, One thing that comes up a little more is that we do worry a little bit more about things like hyponatremia. That is a risk of SSRIs,
Mm-hmm.
SNRIs. Um, it's not usually profound, but since many older adults are seeing more of that anyway, and we're a little more anxious about it, I do
Mm-hmm.
watch that a little more. I would watch for all of the psychiatric medications around things like um, changes to balance or gait,
Mm.
falls, effects on sleep or cognition and confusion, even things that aren't nominally warning you about that.
Mm-hmm.
But especially anything sedating or anxiolytic, I say like, look, these are new chemicals getting in your brain. Could they worsen confusion? Yes. It's not
Mm-hmm.
really likely with most of our antidepressants, but at least be mindful of it. It's probably worth a little more checking in than with our general adult population, where we assume someone would just call us back if they didn't feel that good.
That's great advice. I feel like I've learned to do that, to really limit use of medicine, start very low, check in a
Yeah.
lot, kind of keep
Mhm.
an eye on all the things that I wouldn't be as vigilant on, particularly fall risk, I think, and balance is something that we don't think about nearly enough. And I harp on in this curriculum because falls are the enemy.
Falls are
So
the
that's,
enemy.
yeah.
And it's always worth talking with people too. Here's something, how likely do I think it is to work? And here's the list of things I'm worried about. Do you want to do anything? I also have plenty of older adults who just say, I have too many pills.
Mm-hmm.
I don't want to add anything. What else can I do?
Mm-hmm.
And that can be a very fruitful discussion too.
Yeah.
There are other things people can do that they can do in their, even beyond like therapy, but they can do for themselves in their own lives. And exploring, do you want to try that first? And then we'll come back and think
Right.
about it.
Yes, do nothing. That's definitely one of my favorite things to do is do nothing. Don't add another med if you don't have to. Okay. So final question for you, John. Just tell us a little bit about what types of referrals are,
Mhm.
when should we think about geriatric psychiatry as a referral? When would it be appropriate to do that?
So I think sort of in terms of like the clinical criteria, thinking about specifically when we're talking about people who have like a psychotic depression, definitely.
Mm-hmm.
Um, if people have what I'll say is sort of a kind of a persistent suicidal ideation. I mean, an acute
Mm-hmm.
thing, we may need to contact our emergency services and stuff like that. But there are people who transiently have um, a suicidal ideation that's more than just saying, um, I'd be okay if I passed away in my sleep because I've
Mm-hmm.
had a good life and things are difficult. Um, that's probably worth a referral. Um, I think it's also worth thinking about not necessarily in terms of the depression itself, but either when there's a diagnostic uncertainty, that dementia versus depression one is sometimes worth at least a one-time
Mm-hmm.
consult. And sometimes we can come back and say, here's what I think is going on, and then the plan is very
Yeah.
manageable in any
Yeah.
setting. Likewise, sometimes a consultation around medication use that may be
Mm.
complicated. So
Mm-hmm.
I see a little less in depression, but we sometimes see someone has what seems like a good benefit from a psychiatric medication, but there's new medical reasons why I'm not sure that's a good idea. We might do it anyway.
Mm-hmm.
Less than depression, but one of the classic things is lithium in people who have
Mm-hmm.
progressive kidney disease. Some psychiatric patients say, but I do so well in this. Like that can be fine. But I think when it is complicated like that, sometimes getting at least a one-time consult is useful.
That's great.
Um, and
Mm-hmm.
maybe the third thing is when it's complicated by other neurologic disease. So we see a lot of people with
Mm.
Parkinson's disease, MS, post-stroke. That is sometimes, again, we're happy to see them. They may or may not always need either psychiatry in general or geriatric psychiatry, but it's certainly worth considering.
I have found that very helpful when I have patients who are older, have a neurologic disease, post-stroke, Parkinson's. and they have depression, even just with the medication management. I feel like
Yeah.
your team has been really helpful. The other thing that came to mind was dual diagnosis, so people with
Hmm.
substance use and
Hmm.
depression. I know that can be often a challenge. How do you feel about
Yeah.
that? For
So first, actually, I'm really glad you brought it up because I think alcohol especially goes way under the radar
mm,
for a lot of us in terms of
mm-hmm,
how much our patients may be drinking and how much
mm-hmm.
they may be normalizing it, and how much it impacts their health. And I try to tell everyone, look, as we get older, we get more sensitive to all kinds of medications, but alcohol too. And you may have that may be a perfectly reasonable drinking habit from 30 years ago, but you're 30 years older now.
Mm-hmm.
Um, there's probably a limit on how much we're going to be able to do for their depression from a psychiatric
Mm-hmm.
standpoint if they're not going to address it at all. Um, I don't think it's I think there's room for us still to have a consult and talk with them, but it may only go so far
Yeah,
if they're not
right.
going to change anything else. But uh, I'm surprised sometimes by how much people are willing to modify behavior or at least grapple with it, and see if they can reduce their use. Um, but it's a big problem.
Yeah. It's funny we just brought it up now. It just goes to show like it's not it's oh, I forgot to ask about alcohol when it's
Right.
actually probably should be at the top of
Well,
our
if you talk about like falls and cognition and all these other things, it's terrible. And it is tough. I think it's there's sometimes a great sensitivity to older adults in alcohol and the feeling like they're being called an alcoholic when that may not be it, but their current alcohol use is worsening their health.
yeah.
And I think it's actually, especially if there are very concrete things like falls in an ED presentation, like
Hmm.
something else to really grab on, like this is an issue. Can we use that as a lever to get you to reduce your use, see how that impacts things?
Hmm.
Um, but it's a tough topic.
It is a tough one. All of these topics are very difficult, and I think one thing I take from our conversation is just how we should all be very humbled, I think, by the complexity that we face with folks
Mhm.
as they age. They start to accumulate problems. It gets more difficult to sort out what's what. And really, it makes me thankful that I often can see patients more than once, which we've talked about before, that
Mhm.
sometimes something isn't obvious or addressable in one visit, but maybe over several visits. So give ourselves grace in primary care
Yes.
to to know that we might not get it the first time, but we might get it the third or fourth time, and we
Mhm.
also have the help of people like you and our social workers, our case management to really help us manage this. So thank you so much for spending some time with us and going over this important topic.
Thank you.